بسم الله الرحمن الرحيم. أنا دكتور إسلام كريم، مدرس الجراحة في وحدة جراحة الكبد والمرارة والبنكرياس، كلية الطب جامعة اسكندرية. بالنسبة لللكتشر اللي هنقولها النهارده هي Diagnostic Biliary Imaging. دي واحدة من اللكتشرز المهمة جدا. يعني Learning Objectives اللي احنا عايزين نقولها اللي هو بعد نهاية المحاضرة دي you should be able to identify different types of biliary tract imaging و to identify شوية brief information عن التكنيك بتاع كل imaging modality بتتعمل، واهم حاجه في الاخر ان احنا بعد ما نعرف اسم البيلياري تراكت imaging we should diagnose what's the pathology within this biliary tract image supplied في السلايد او في الامتحان زي ما هنشوف. طيب لما نيجي نتكلم what are the types of biliary tract imaging modalities، ايه هي الايمجنج modalities اللي احنا بنصور بيها البيلياري تراكت؟ Number one is transabdominal ultrasound. Number two, endoscopic retrograde cholangiopancreatography, which is known as ERCP. Number three, percutaneous transhepatic cholangiogram or PTC. T-tube cholangiogram, intraoperative cholangiogram, magnetic resonance cholangiopancreatography or MRCP, and computed axial tomography or CAT scan. كل دول هم عبارة عن imaging modalities نقدر ناخد بيها فوتو او ايمج للبيلياري تراكت to identify its anatomy and the pathology اللي موجود فيها. طيب to begin with transabdominal ultrasound زي ما احنا شايفين في الصوره، هي دي صوره كده to briefly show how do you do a transabdominal ultrasound. يبقى السونوجرافر او الراديولوجيست واقف وباصص على المونيتور اللي قدامه وماسك الترانسديوسر اللي بيبقى موجهه ناحيه الابدومن بتاع البيشنت، وعن طريق حركه معينه بالترانسديوسر بيبتدي يشوف ثرو ان اكوستيك ميديوم او ثرو ا ميديوم، لازم يبقى فلويدي ميديوم تقدر الالتراسونيك ويف دي تتحرك جوه الجسم، وكل ما تقابل دنسيتيز معينه تبتدي تدي شادوز اوف براي. كل ما الحاجه تبقى ايكوجينيك كل ما تبقى لونها وايتش ان كلر، كل ما الحاجه تبقى لوسنت تبتدي تدي البلاكش كلر. طيب لما نتكلم على الترانس ابدومينال التراساوند دي بنعتبرها the most initial imaging modality to be done for any biliary tract pathology. تمام. تاني حاجه هي تعتبر the best imaging modality for the gallbladder diseases، يعني بالنسبه للجول stones gallbladder polyps دي تعتبر هي البيست imaging modality for gallbladder diseases. طيب لما نيجي نتفرج كده على شكل الالتراساوند عشان اقدر اعمل ايدنتيفيكيشن تيبيكال كده، انا هلاقي الشكل اللي مرسوم بالمنظر ده بتاع الالتراساوند خلاص، وهلاقي فيه الشادو بتاع التيشوز اللي حواليا كده زي الليفر، وابتدي اشوف حاجه كده ايكولوسين، دي يوجوالي بتبقى الجول بلادر. As we know ان الالتراساوند it's operator dependent و it's a real time imaging، فذاتس واي هي لما بتبقى اوبريتور ديبندنت هو بيبقى عامل زومينج تو ماتش، ما هياش اكزيال سكان زي السكان مثلا بتاع السي تي زي ما هنشوف ان انا شايف كل الابدومين، فانا بالتالي لو الراديولوجيست مش موجود انا اقدر ك انترنست كانترنال ميديسن او سيرجن زي حالاتي نقدر نقول ان دي هنا ليفر، ده هنا سبلين، دي هنا جول بلادر. لا الالتراساوند ما هياش بالمنظر ده، هي الالتراساوند بتبقى فوكسد على الاورجن وانت شايف جزء من اورجن. ذاتس واي لما انا واحد يجيب لي الصوره بتاعت الالتراساوند وهو مش مشاور لي الاسهم دي عباره عن ايه، I could never diagnose هو الالتراساوند ده almost باصص على ايه. ذاتس واي احنا دايما بنقول اس اوبريتور ديبندنت، زي ما الاوبريتور بيقول لك او الراديولوجيست بيقول لك دي جول بلادر انا هصدقه ان دي جول بلادر، جواها ستون انا هصدق ان جواها ستون، هبقى شايف طبعا ان جواها ستون وكل حاجه، بس هبقى متاكد انها جول بلادر عشان هو قال لي جول بلادر. ذاتس واي اتس كولد اوبريتور ديبندنت. طيب من ضمن اهم الديزيز اللي بنكتشفها باي التراساوند في الجول بلادر از جول بلادر ستون. طب ايه الكاركتر بتاعت الجول بلادر ستون؟ يوجوالي هنلاقي الجول بلادر هي عباره عن بلادر كده فيلد ويز ايكولوسنت لومين خلاص لونه بلاكش ان كلر، وهنلاقي فيها حاجه ايكوجينيك، يوجوالي بيبقى التيرم بتاعهم في ريبورت ان ايكوجينيك ستون ذات هاز ان اكوستيك شادو. طيب يعني ايه ايكوجينيك ستون؟ ايكوجينيك لما نقول حاجه ايكوجينيك يعني حاجه لونها towards the whitish color بالالتراساوند، حاجه ايكولوسنت يعني زي ما قلنا حاجه لونها بلاكش ان كلر، فدي لونها ايكوجينيك. ده الجول بلادر، ده الانترنال وول بتاعها، وشايفين فيه سايزبل ستون موجوده لونها ايكوجينيك. النقطه ان لما الالتراسونيك ويف بتعدي ثرو ا هارد ماتيريال زي الستون اللي موجوده خلاص it throws a shadow behind this echogenic stone. فالستون بتبان ايكوجينيك however وراها ما بيقدرش الالتراسونيك ويفز to migrate through the tissue، فبالتالي بترتد تاني وبتدي شكل الاكاستيك شادو المشهور اللي موجود وراها. فدايما بيبقى عندنا شكل ستون بتتقال في الريبورت ان هنا we have an echogenic stone that throws an acoustic shadow خلاص، وده اشهر زي ما قلنا تعبير في الالتراساوند فور جول بلادر ستون. لو بصينا لصوره ثانيه، صوره جميله جدا، ادي شكل الليفر تيشو خلاص بالبورتال تراكتس اللي موجوده، ده شكل الجول بلادر خلاص ليها ايكوليوسنت لومن كل مليان بايل كلير خلاص، واضح ان انا عندي اجين ايكوجينيك شادو خلاص وثروينج ان اسف هي ايكوجينيك وثروينج ان اكاستيك شادو خلاص posterior to this stone، فبالتالي اقدر اعرف ان دي هارد سبستانس جوه الجول بلادر يوجوالي ايتس ا ستون، وده اللي يمكن بيفرقها عن اذر باثولوجي موجود جوه الجول بلادر such as جول بلادر polyps. البوليب بتبقى عباره عن more or less ايكوجينيك، هي بتبقى less ايكوجينيستي عن الستون لانها بتبقى more or less it's a soft tissue usually it's a cholesterol polyp however it never throws an acoustic shadow زي في حالات الجود ستون because it's not a hard substance as the stone. Another ultrasound image برضو شايفين شكل الالتراساوند، واضح ان هو هنا بيقول لي البروب بتاعي واقف شكله فين، واضح ان انا عندي جول بلادر showing multiple echogenic stones with throwing acoustic shadow زي ما احنا شايفين بالمنظر ده. طيب لما نيجي نبص على الرول اوف ultrasound in diagnosing bile duct pathology، طيب يعني احنا قلنا في بالنسبه للالتراساوند هو يعتبر البيست فور جول بلادر ديزيزز. طيب واتس ذا رول اوف ultrasound بعد ما بعدنا عن الجول بلادر لما اشوف البيلياري تري البايل داكت. البايل داكت دي او البيلياري تري بتتقسم لجزئين، جزء انترا هيباتيك والجزء الثاني هو اكسترا هيباتيك بيلياري تري، فبالتالي انا عندي الجزء الانترا هيباتيك الالتراساوند كان جيف مي ا فيري جود ايديا اباوت ذا كاليبر اوف ذا انترا هيباتيك بيلياري تري، ولسه هنشوف السيجنيفيكانس بتاعه خلال كام صوره اللي جايين. ولكن لما انا بتكلم على الاكسترا هيباتيك بايل داكت هي عباره عن الكومن بايل داكت اللي احنا شايفينها كده بحركه معينه برضو من الراديولوجيست لما بيحرك الترانسديوسر بطريقه معينه على الابدومين يبتدي يشوف التوبولار ستراكشر اللي موجود في الفري مارجن اوف ذا lesser omentum خلاص towards the right side اللي هي الكومن بايل داكت خلاص posterior to it is the portal vein تمام. وشايفين ان بطول الكومن بايل داكت الدنيا كويسه خالص لحد ما نيجي هنا لايكوجينيك ستراكشر اجين خلاص بنفس الكرايتيريا بتاعت الالتراساوند وثروينج ان اكاستيك شادو، فبالتالي احنا كده نكون شخصنا ان انا عندي في كومن بايل داكت ستون موجوده في الديستال اند. How much would the ultrasound how possible would an ultrasound identify a common bile duct stone? It's not as high as its ability to diagnose a gallbladder stone. ليه؟ لأن لو بصينا للاناتومي بتاع الcommon bile duct, the common bile duct runs into the free margin of the lesser omentum and it runs behind the first part of the duodenum, then within the head of the pancreas, which is again behind the hepatic flexure of the colon, to insert into the second part of the duodenum through the ampulla of water خلاص together with the pancreatic duct. فهي في الرحلة بتاعت الcommon bile duct from the liver to its insertion into the second part of the duodenum, it passes behind multiple lumen with gases. وعضو الالتراساوند you will always know that the enemy of the ultrasound is the presence of gas. دايما it masks any organ behind this gas. That's why an ultrasound it's not an image for any retroperitoneal structure. اي حاجه ورا البيريتونيوم ورا الباول لوبس دي كلها الالتراساوند is not a good imaging for identifying accurately any retroperitoneal structure. فبالتالي الديستال part of the common bile duct usually is masked by gases، وبالتالي في حالات كتير ممكن يبقى عندنا distal common bile duct stone بس الالتراساوند is unable to identify، مش لحاجه لمجرد ان هي it's just masked by the gases اللي موجوده في الديودينم او في الهيباتيك فليكشر. فبالتالي يعني في العينين ممكن اللي هم بيبقوا very thin very well prepared خلاص مفيش جازز ماتش في الكولون او في الديودينم نقدر نعمل ايدنتيفيكيشن لكومن بايل داكت ستون زي ما احنا شايفينها لو هي موجوده ديستالي بالمنظر ده. طيب لو بصينا على صوره ثانيه برضو هي صوره هتلاقوها very zoomed in خلاص، ولو احنا بصينا اي حد هيبص عليها he would never identify ان دي common bile duct unless يبقى الراديولوجيست قال لك ان this is a common bile duct. again we are confirming it's operator dependent. واضح ان هي فيها two echogenic structures موجود، وبرده throwing الاكوستيك شادو المشهور بتاعهم، فبالتالي I would identify ان دول these are two distal common bile duct stones with the classical criteria within the ultrasound. طيب نيجي بقى للجزء الانتراهيباتيك biliary radical by ultrasound. Ultrasound is again one of the best imaging modalities to identify pathology within the intrahepatic biliary radicals، وبتبقى اشهر حاجه في الانتراهيباتيك biliary radicals ان انا يبقى عندي dilatation of the intrahepatic biliary radical. ودايما بنقول what's the significance، يعني ايه السيجنيفيكانس ان انا اقول ان انا عندي dilated intrahepatic biliary radical؟ it usually signifies that there is an extrahepatic bile duct obstruction. whenever ان انا عندي obstruction by the end of the distal bile duct البريشر بيبقى built up within the common bile duct و becomes transmitted to the intrahepatic biliary radicals، فيبتدي يحصل لهم dilatation، ودي بتبقى one of the earliest signs اللي موجوده for extrahepatic bile duct obstruction. فيوجوالي لما بنبص بالالتراساوند في patient who is jaundiced خلاص انا بوديه على طول يعمل مع اللاب انفستيجيشنز توتال اند دايركت بالروبين الكلاين فوسفاتيز وكل الكلام ده. بقول له روح اعمل التراساوند از ان انيشال ستادي، وزي ما اتفقنا الالتراساوند هي الموست انيشال خلاص ايمجنج موداليتي اي حد بيطلبها خلاص فور ا جاندست بيشنت. اول ما الالتراساوند يقول لك ان في عندي dilated intrahepatic biliary radicals I have to identify that this jaundice is a cholestatic or it's a post-hepatic jaundice، يعني it may be of surgical significance او زي ما بنقول it's a surgical jaundice that may need to be managed by surgery. لان في الحالات الثانيه طبعا as you know من other types of jaundice في عندنا pre-hepatic jaundice, hepatic jaundice and post-hepatic jaundice. Pre-hepatic and hepatic jaundice they usually don't come with intrahepatic biliary radical dilatation، لان بتبقى الباثولوجي في البري-hepatic انا عندي hemolysis خلاص it does not have any intrahepatic biliary radical dilatation. وفي الhepatic jaundice I have a problem with the excretion خلاص of bile into the circulation into the bile ducts, or I have a problem with conjugation of bile. فبرضه it doesn't have anything to do with the intrahepatic biliary radical diameter. فبالتالي في pre-hepatic and hepatic jaundice there is usually no intrahepatic biliary radical dilatation، وده اللي بيفرق لي الجاندس اللي هي it may need internal medicine attention خلاص اللي هي pre-hepatic and hepatic عن post-hepatic jaundice or cholestatic jaundice اللي هي بتبقى obstructive jaundice that has intrahepatic biliary radical dilatation that requires usually surgical intervention. طيب لما نبص في الصوره دي هنلاقي ادي شكل الجول بلادر بالمنظر ده خلاص، وبحركه البروب برضو هو مشاور لي على السهم وقال لي ان this is a dilated intrahepatic biliary radical, this is another biliary radical dilated and so on. خلاص تمام جدا. طيب دي بالنسبه للالتراساوند. let's move on لحاجه بقى more invasive تمام which is endoscopic retrograde cholangiopancreatography or ERCP as it stands for endoscopic retrograde cholangiopancreatography. This is a type of an imaging modality that is done by an upper GIT endoscope. Usually we call it a modified upper GIT endoscope لان هو الموديفيكيشن اللي فيه ان انا بدخل زي ما انتم شايفين الاندوسكوبس بيبقى واقف وماسك الاندوسكوب في ايده خلاص، والبيشنت بيبقى واخد جنرال انستيزيا، والاندوسكوب بيخش through the mouth and then through the oropharynx, through the esophagus and then into the stomach until it passes to the second part of the duodenum. هنا الاختلاف عندي عن الابر جي اي تي اندوسكوب ان ده ما هوش اند فيوينج لينس، اللينس بتاعته ما هياش في الاند بتاعت الاندوسكوب، لا هي في السايد بتاع الاندوسكوب. اتس ا سايد فيوينج اندوسكوب، ذاتس واي وي كول ات ا موديفايد ابر جي اي تي اندوسكوب. طب ليه اللينس بتاعه في السايد؟ لو بصينا كده انا بقف بالاندوسكوب ده في السكند بارت اوف ذا ديودينم عشان اقدر ابص على البابيلا اللي انا هعملها كانيوليشن، والبابيلا دي هي السمت خلاص اللي موجود عليها الاند بتاع الكومن بايل داكت اند ذا بانكرياتيك داكت. فwhenever I reach the papilla I can cannulate the papilla وابتدي احقن الكونتراست بتاعتي فاشوف الصبغه كويسه موجوده في common bile duct and the pancreatic duct. فبالتالي السايد فيوينج لينس دي اول ما بيقف الاندوسكوب في second part of the duodenum زي ما احنا شايفين يبتدي اطلع واشوف البابيلا اللي هي موجوده هنا، ابتدي اطلع الكاثيتر بتاعتي واعمل cannulation to the common channel خلاص and then I would inject my contrast material to fill the common bile duct and the pancreatic duct, by which we can do an endoscopic, because we are using an endoscope. Retrograde, because the common bile duct is filled in a direction opposite to the flow of the bile. The bile flows from the liver to the duodenum. انما انا I'm filling the bile duct with contrast from the duodenum up to the liver, فتسمت retrograde. And cholangiopancreatography, since I'm viewing both with the contrast and viewing the common bile duct and the pancreatic duct. طيب لما نيجي نتكلم على ال ERCP as an ERCP, it's very important to know what's an ERCP. زي ما قلنا this is the technique. تاني حاجة ايه ال advantages of the ERCP. ERCP is having the advantage of being a diagnostic and a therapeutic modality. يعني اقدر اعمل بيها diagnosis زي ما انا بصور كده عشان اخد cholangiopancreatography خلاص، ولو لقيت pathologies معينة I can deal with it still while I'm in the same session of the endoscope زي ما هنشوف كمان شوية. الحاجة التانية we have to know in ال ERCP it requires contrast injection خلاص، عشان اشوف الحاجة اليومينال اللي هي اليومين بتاعت الكومن بايل داكت واليومين بتاعت البانكرياتيك داكت I have to inject a contrast جوه اليومينا دي، فبالتالي it's an invasive procedure. تمام، وكل invasive procedure has its own drawbacks او complications زي ما هنقول في الاخر خالص بعد ما نخلص ال imaging diagnostic modality of the ERCP. طيب لما نيجي نتفرج على شكل normal ERCP, to know the abnormal you have to know first what's the normal ERCP. So looking at this image I can see that the key in this image is that I'm having a biliary tree متصورة بالمنظر ده خلاص. دي intrahepatic biliary radicals بيبقى شكلها feather like خلاص very narrow خلاص، زي كأن واحد ماسك كده قلم رصاص كده وعامل خطوط very narrow بالمنظر ده خلاص. ده منظر ال left hepatic duct، ده منظر ال right anterior hepatic duct right posterior hepatic duct. This is the common right hepatic duct، ادي left ادي right ادي common hepatic duct. This is the cystic duct تمام and this is the common bile duct خلاص. This is the pancreatic duct خلاص and this is the common channel اللي بتبقى موجودة قلنا واللي بيقف قدامها الاندوسكوب for cannulation. طيب شكل النورمال ERCP ان احنا زي ما قلنا الانتراهيباتيك biliary radicals بيبقى شكلها very narrow and thin spider leg like if we could say تمام. The diameter of the common bile duct, normal common bile duct, I would say that its diameter is normally up to 6 or 7 millimeter maximum. ما بيتعداش ال 6 or 7 millimeter. if I'm supposedly شايف ان الاندوسكوب ده is around مثلا 15 millimeter, I would say a rough measurement. a normal bile duct should not exceed 50% of the diameter of the endoscope. فكل ما الاقي ان ال common bile duct دي within half the diameter of the endoscope اعرف دايما ان الدايمتر بتاع الكومن بايل داكت دي is normal. تمام. طيب تعالوا نبص على جنب الصوره دي عشان ابتدي اتعرف على الابنورمال. نبص على ابنورمال اي ار سي بي. اجين هبقى شايف ده البيكتشر، ده الاندوسكوب اللي موجود خلاص وهو متاخد باي ذا اكس راي خلاص. دي الكومن بايل داكت and this is the intrahepatic biliary radicals. طبعا when we compare both images there is a marked difference between both images. If we look at the intrahepatic biliary radicals طبعا شكلها هنا hugely dilated intrahepatic biliary radicals. لو جينا نبص على الكومن بايل داكت in comparison مع الكومن بايل داكت دي طبعا hugely dilated common bile duct. لو احنا بقى عايزين نكمبير الدايمتر بتاع الكومن بايل داكت دي with the corridoscope with the endoscopic diameter طبعا it's bigger than the endoscope diameter, ف it means ان هي طبعا markedly dilated. طيب الحاجه اللي انا عايز اشوفها ايه اللي عامل الدايلاتيشن ده. definitely there is a distal obstruction مخلي البايل داكت دي with intrahepatic biliary radicals to be that much dilated. ف I have to look for this filling defect. This filling defect is there, which means that I have most probably a stone at the distal end of the bile duct. Okay, this is a single distal filling defect خلاص. فما اقول what's the differential diagnosis of a single distal filling defect خلاص from 1 up to 100 لازم تبقى الانسر بتاعنا it's most probably a single distal common bile duct stone causing obstructive jaundice. Okay, or causing obstruction. تمام. طيب لما نبص على صورة تانية for the ARCP, this is again an endoscope crossing in front of the biliary tree بالمنظر ده زيها زي الصورة اللي قبلها. كل endoscope is usually crossing in front of the biliary tree لأنه بيبقى معدي في الستومك، معدي في الفيرست part of the duodenum وبيقف في السكند part of the duodenum والفيرست part بيبقى قدام البايل داكت. ف it's usually crossing in front of the bile duct. نفس المنظر. هنا الفرق ان انا عندي multiple variable tiny sized filling defects. خلاص. و filling defect we mean in while I'm filling the bile duct with the contrast material there are some areas that did not fill with contrast. هما اللي بيappear عندي as filling defects. هنبص على المنظر. طبعا classical faceted stones or structures within the bile duct, most probably these are multiple tiny variable or variable sized common bile duct stones. نيجي نبص على صورة ثالثة. Again to confirm what we have seen, this is again an ERCP or endoscopic retrograde cholangiography. To be more specific, because we don't see the pancreatic duct, we just see the common bile duct, so it's endoscopic retrograde cholangiography. Okay, and it shows multiple variable size filling defects, again filling the common bile duct from its proximal end to its distal end. Most probably these are multiple common bile duct stones. تمام. لما بنيجي نتكلم على المانجمنت how do I need to manage، خلاص يعني quickly speaking كده بنحتاج ان احنا نعمل clearance of this bile duct from stones. We have only two methods to clear the bile duct from stones, either by using ERCP وده بقى هيبقى therapeutic role بتاع ال ERCP, or we can use surgical common bile duct exploration عن طريق ان انا بعمل incision longitudinal incision within the common bile duct وافتح ال common bile duct وابتدي اعمل extraction of the stones from the common bile duct. معتمد ان انا اختار على ايه، على اي اساس whether to choose CBD exploration اللي هي surgical او ان انا اعمل common bile duct clearance by ERCP. هعتمد على size of the stone. we will have an agreement on something that if we have a stone or stones that are within 1 centimeter in diameter, these are usually amenable for extraction by ERCP. However, when we have multiple stones or a stone that is more than 1 centimeter, يعني hugely dilated, يعني 1.5 centimeter, 2 centimeter stone, huge stone, this is usually not possible for ERCP to extract, and usually it's indicated for surgical common bile duct exploration. صورة تانية اللي بنبص فيها على again ERCP. This is the endoscope crossing in front of the bile duct showing multiple filling defects again. تمام. variable sized multiple common bile duct stones. The best way to manage is definitely surgical common bile duct exploration. طيب نبص على pathology تاني other than the common bile duct stones. I can see again that this is an ERCP. I can see the endoscope. I can see the bile duct. Here I can see the pancreatic duct. So this is a pure ERCP, endoscopic retrograde cholangiopancreatography. However, I do not see any filling defect within the bile duct in the form of stones. أنا مش شايف الكلام ده. However, I can see that there is likely a lesion here that is causing a dilated common bile duct and a dilated pancreatic duct. خلاص. whenever we have a dilated common bile duct and a dilated pancreatic duct, this sign is a very important radiological sign and it's called a double duct sign. Double duct sign, from its name, it means dilated both common bile duct and dilated pancreatic duct. And whenever we have a double duct sign, it usually means that there is an obstruction distal to both ducts which make them dilated. Usually بيبقى obstruction at the site of the common channel زي ما شفنا كده anatomically في الصورة دي سريعا. ان انا عندي الcommon bile duct مع البانكرياتيك duct فاتحين في common channel بالمنظر ده، فبالتالي اي حاجه هتعمل obstruction في الكومن شانل او عند الليفل ده، فبالتالي لا البايل هيبقى able to access or to gain access to the duodenum nor the pancreatic juice will be able to access its way to the duodenum. فبالتالي هيبقى في obstruction to the flow of bile and pancreatic duct from the common bile duct and the pancreatic duct respectively. هيبقى في pressure build up فبالتالي هيبقى في upstream dilatation of the common bile duct and the pancreatic duct. Whenever we have this sign, this is called a double duct sign. And what is its significance? It usually signifies that there is a pancreatic head mass. Okay, so pancreatic head mass, it's just a mass. It may be a benign mass as in fibrosis due to chronic pancreatitis, or it may be a malignant mass as in pancreatic head cancer. تمام. This is very important to identify or to learn by heart a double duct sign as this image. طيب تعالوا نبص على الايمج دي. This is again an image done by ERCP. However, the odd thing here that we don't see the endoscope. خلاص. However, there is not an imaging modality that can visualize the common bile duct and the pancreatic duct by injecting a contrast except ERCP. This is an ERCP. خلاص. الباثولوجي اللي احنا شايفينه ان احنا شايفين فيه dilated pancreatic duct like this, dilated common bile duct, but there is another pathology. خلاص. We have a diverticulum, we have a cystic swelling that is arising from the side of the common bile duct. Okay, this is what we call a type 1 choledochal cyst based on the modified Tudani classification of the choledochal cysts. خلاص. What you need to do about a choledochal cyst is that it is a pre-malignant condition. It is usually common among young aged female patients, and it usually presents in up to 40% of patients. It presents with a triad in the form of abdominal pain, tender abdominal mass, and jaundice. And the jaundice is due to recurrent cholangitis من السويلنج اللي بيبقى موجود، السيستيك swelling اللي موجود وبيحصل فيه biliary stasis and recurrent stone formation and inflammation، فبالتالي بيعمل recurrent cholangitis. You need to know that this case is pre-malignant, and whenever we diagnose a choledochal cyst, it has to be excised. Another form, this is an ERCP. واضح طبعا ان انا I see the endoscope. This is the biliary tree. Slight dilatation خفيف يعني، بس واضح ان انا عندي هنا fusiform dilated structure within the structure of the bile duct. نازل كان البايل duct normal كده، وبعدين all of a sudden حصل fusiform dilatation. This is what we call again a choledochal cyst. However, to be more specific, it's a type 2 choledochal cyst again according to the Tudani classification. فالفرق ما بين type 1 ان انا عندي بيبقى cystic diverticulum arising from one side، يعني common bile duct نازله normal، فجأة طلع منها stalk وطلع منها cystic dilatation واللي احنا بنسميه diverticulum خلاص arising from the common bile duct. However, الفرق هنا ان لا، ده انا هنا عندي في fusiform dilatation within the body of the bile duct. تمام. فدي type 2 اللي هي الفيوزيفورم like structure. طيب this is a third pathology. خلاص. من اللي احنا بنشوف، احنا شفنا كده for ERCP شفنا common bile duct stones، شفنا double duct sign for pancreatic head mass، شفنا choledochal cyst، وده رابع باثولوجي بنقدر نشوفه ان انا اجين عندي الاندوسكوب واضح ان انا عندي في common bile duct is visualized until suddenly there is like a narrowing or a stricture as we can see here in the proximal part of the bile duct just distal to the confluence of the right and left hepatic ducts with upstream dilatation of the intrahepatic biliary radicals. طيب فبالتالي انا radiological I will diagnose that this is a stricture or narrowing or obstruction or shouldering is seen at the confluence of the right and left hepatic ducts or at the proximal common bile duct, and we have many differential diagnoses. It may be a benign stricture, it may be a malignant stricture as in cases of cholangiocarcinoma. اشهرهم بتبقى حاجه اسمها clad skin tumor اللي هي بتبقى cholangiocarcinoma occurring at the confluence of the right and left hepatic ducts. It may be enlarged lymph nodes at the pora hepatis وعاملين obstruction in a patient for example with a lymphoma. It may be a post-operative event due to obstruction or due to ligation, inadvertent ligation of the common hepatic duct which was wrongly perceived as the cystic duct. We have many differential diagnoses for this stricture to give. Again, this is a fifth pathology. We can see كل اللي انا شايفه هنا جزء من الاندوسكوب and this is the biliary tree. والواضح هنا في البيلياري tree ان انا ولا عندي dilatation ولا عندي stricture. I have a mixture of both. I have areas that show slight dilatation like this, like that, and areas that show narrowing like these segments. So this is what we call the beaded appearance of the common bile duct or intrahepatic biliary radicals, and this is a very characteristic sign or very characteristic imaging for what we call the PSC or primary sclerosing cholangitis. Briefly speaking, the PSC or primary sclerosing cholangitis, it is a genetic or maybe an autoimmune disease that takes place within the biliary tree, okay, and leads to fibrosis of certain parts of the bile duct, skipping other areas. So the areas which develop fibrosis, they undergo stricture, and the areas which do not develop fibrosis, since there is a stricture and obstruction, they undergo dilatation. And then an area again develops stricture, another area develops proximal to it dilatation. So it has a stricture, dilatation, looking like a bead. So it's a beaded appearance. Okay, it's usually associated with certain other autoimmune diseases such as ulcerative colitis and Crohn's disease, most probably ulcerative colitis. يعني من الحاجات اللي تبقوا عارفينها for primary sclerosing cholangitis, and it does not have any treatment except liver transplantation in the current, based on the best knowledge we have, there is only liver transplantation as a solution for PSC in those patients. Okay, so by that we have ended the diagnostic part of the ARCP. As we saw, it's all about images. We are injecting a contrast, we're taking X-ray, and we are seeing the image and diagnosing the pathology. But what's the therapeutic role? As we said, another advantage of ARCP, it has a therapeutic role, so it can manage certain pathologies. One of the most important of which is stone extraction. So whenever we did an ARCP and we found a stone that is amenable to be extracted by ARCP, and what we mean amenable is that anatomically it's within a common bile duct that is easy to be cannulated, and the stone is within 1 centimeter in diameter, whatever the number, maybe 2 stones, 3 stones, as long as they are within 1 centimeter, they can be extracted. Okay, so what are the tools that we can use or the endoscopist can use to extract the stones? Usually we have two tools, either the Dormia basket, as you can see this tool with those spokes, this is the Dormia basket, or you can extract it using what we call the balloon catheter. Okay, so as an image, this is the Dormia basket, okay, and you can see the stone engulfed into this basket. So I insert the Dormia basket and I try to manipulate it until the stone gets into the cage, and then I pull the cage with the stone until I can deliver it on the table with me. Or I can use the balloon catheter as in those cases, and we usually use balloon catheters whenever we don't have like an actual stone, however, like biliary mud or just very tiny stones that cannot be engulfed by the Dormia basket, because they will just flow out of the spokes. So we can use a balloon catheter by throwing the catheter up to the highermost point in the bile duct, deflated, and then we have to inflate it a little bit, and then we can pull so that the inflated balloon would sweep down those, as we can see, those tiny stones out, so that they can just be excreted in stool. This is a real photo for a stone that is being extracted by Dormia basket. This is the Dormia basket, and it's getting out of the papilla or the ampulla of Vater. Another therapeutic role of ARCP is that it can help to insert stents. Okay, this is the shape of a stent. It's usually a plastic stent, okay, and it may be covered or uncovered, whatever. It's just a stent that can be used to be inserted into the common bile duct via ARCP. When do we use stents? We can use stents, for example, if we found that the patient is having a stricture in the distal bile duct. So instead of just getting out and letting the patient jaundice again, we can put a stent. If there was a stone that failed to be extracted by ARCP, so without the ARCP just getting out and sending the patient to surgery, we can put a stent, the endoscopist can put a stent just to relieve the jaundice of this patient, okay, and prepare him for surgery to do common bile duct exploration. It can be also placed whenever patients have a malignant stricture or pancreatic head cancer that is inoperable, okay, or if the patient is operable and resectable, he can put it if the patient is having very high jaundice and he cannot go for surgery like this and he needs to be prepared. So he can put the stent. That's why it's an invasive maneuver, it's a therapeutic maneuver, and it's one of the advantages of the ARCP. This is again an image of this bluish plastic stent that is inserted through the ampulla of Vater, and it helps to drain bile, okay, through this channel to the duodenum, and thus helps to reduce the total and direct bilirubin levels into the serum and improve the patient's condition, either to be prepared, as we said, for surgery, or to be used as a symptomatic treatment for jaundice for patients who have an advanced malignancy as cancer of the pancreas that is metastatic or so on. The third imaging modality that is of clinical significance and importance for all of you to study is the percutaneous transhepatic cholangiogram. And it gains its PDC or its acronym from the name, percutaneous for P, transhepatic for T, and cholangiogram for C. And as we can see in this image, it summarizes what happens in this technique. So we use at first a needle. This is a sharp needle or a puncture needle that is called a Shiva needle. Okay, we go through the needle into the skin, so it's percutaneous, and then after the skin we go through the liver parenchyma and it's transhepatic, and then we identify by the ultrasound where is the tip of the needle is going. So we can see that the patient is having jaundice and having intrahepatic biliary radical dilatation, and I can see the tip of the needle inserted into one of the dilated intrahepatic biliary radicals. That's when the interventional radiologist starts to aspirate out from the end of this needle, like here he starts to aspirate. If it came bile, so well and good, so the needle is situated in the right side, which is one of the dilated intrahepatic biliary radicals. If it gave out blood, so still we are not in the correct side, so he keeps manipulating until it gets into one of the dilated intrahepatic biliary radicals, and when the aspirate is bile, this is when he can get the contrast and inject it into these dilated intrahepatic biliary radicals to give us the C, which is the cholangiogram. So briefly, to know what are the instruments we use for a percutaneous transhepatic cholangiogram, that's what we said, the puncture or the Shiva needle. This is its shape. It's a needle that has a sharp end. Okay, it is a wide caliber a little bit, as we can see here or here. Okay, and it's very interesting to say that by just injecting a contrast into this needle, which is situated into the intrahepatic biliary radicals, we do a percutaneous transhepatic cholangiogram. However, this is usually a step number one if we need to insert, as we see this stent. This is what we call a pigtail catheter. It's similar to the catheter that you see in patients having obstructive jaundice being prepared for surgery. It's put percutaneously, to the contrary of stents that are put by endoscope. Usually stents اللي احنا شفناها by endoscope, these are internal stents. Okay, they are within the common bile duct and open into the duodenum. You don't see anything of the stent outside. Okay, however, those stents, those have an outside end coming out from the skin because it's percutaneous, and an inner side that goes through the common bile duct, so they drain the bile out through a bag connected to the end that is outside the common bile duct. So the PTC may be an initial stage towards placing what we call the pigtail catheter, which whenever it's put, we call it a percutaneous transhepatic biliary drain. It's a percutaneously transhepatic inserted biliary drain. So it's the second stage when we need to do. So what I want to mean is that we cannot do a percutaneous transhepatic biliary drain, we cannot insert it without doing a PTC as an initial stage to make sure that I'm within the intrahepatic biliary radicals. Why am I saying all this information? Because this image, to diagnose, you need to identify the key for this image. So okay, you see an X-ray having biliary tree. I don't see an endoscope, but what you can see is that there is a sharp needle, straight needle that is going into the intrahepatic biliary radicals or into the highermost aspect of the image. Okay, it's not going through here, it's not going through the distal end, it's going through the uppermost aspect of the biliary tree. So this is a percutaneous transhepatic cholangiogram. Okay, usually a percutaneous transhepatic cholangiogram, being an invasive maneuver, it needs to have two prerequisites. As we said, number one, I should have a patient having obstructive jaundice and having dilated intrahepatic biliary radicals. But number two, since it goes through the liver parenchyma, I need to make sure that this patient is not having any coagulopathy, so that when I take the needle out, the patient wouldn't bleed inside his abdomen and develop internal hemorrhage, which may necessitate surgical intervention. So I should have those two prerequisites. Usually in the past, they resorted to a PTC for any patient who had a proximal biliary tract obstruction, usually at the level of the right or left hepatic ducts or the confluence or the proximal bile duct. However, when we had patients having a distal bile duct obstruction, like a stone, like a pancreatic head mass, like a distal stricture, they usually resorted to the ERCP. So whenever you have a PTC, always look to the proximal part of the biliary tree regarding the hepatic duct area, common hepatic duct area, the right or left hepatic duct area, and the common hepatic duct or the proximal bile duct. What we can see here is there is what we call a sudden arrest of the contrast flow within the rest of the common bile duct. There is proximal bile duct dilatation, intrahepatic biliary radical dilatation, which means that there is a sort of obstruction at this level. So what's the differential diagnosis? We can give many differential diagnoses. Maybe there is a type benign stricture, there is a type malignant stricture, maybe there are external compression by enlarged lymph nodes at the pora hepatis in a patient who is having either lymphoma or whatever. Maybe if this patient is in a situation that he is in a post-operative state, he did a laparoscopic cholecystectomy or open cholecystectomy, maybe there is inadvertent ligation of the common bile duct by a suture that made this ischemic stricture. So we have many differential diagnoses for this image. So usually the image gives you the finding, but it does not tell you what's going on. So it gives you that there is a bile duct obstruction, but what's causing the obstruction? Further imaging modalities like a CT scan or MRCP may be required to identify further what's the situation. This is a benign or malignant or whatever. Definitely this is indispensable from having a good history from the patient to know whether he did a surgery before, he did a cholecystectomy before, so maybe it's a mishap or a complication of this surgery and so on. Again, that's why I was telling you about the PTC and the Shiba needle and the pigtail. This is a percutaneous transhepatic cholangiogram. However, what you can see, the key here is this pigtail catheter. This time it wasn't the Shiba needle. It was done through the catheter I have inserted on top of the Shiba needle, which is the pigtail catheter. So to sum up, a PTC can be done through either a Shiba needle as in this image or a pigtail catheter as in this image. Okay, for both of them you can see them entering through the highermost aspect of the biliary tree, which are the intrahepatic biliary radicals, and again we can see that the intrahepatic biliary radicals are dilated, the hepatic right and left ducts are dilated, and there is a narrowing or rat tail appearance or shouldering, okay, happening at the just distal to the confluence of the hepatic ducts and proximal to the beginning of the bile duct. This is usually what we call a stricture at the confluence. Most probably this may be a benign stricture, but most commonly it's a malignant stricture, and when we say a malignant stricture, it's usually a cholangiocarcinoma at the confluence, which has a famous name known as Klatskin tumor. This is, again, I can see this is a biliary tree. This is right hepatic duct. This is left hepatic duct, this is right hepatic duct, and I can see that there is arrest of the contrast, and this is the catheter that inserted or injected the contrast into the biliary tree. Again, it's going through the highermost aspect of the biliary tree, and then so it's a PTC. And what I can see is there is sudden arrest to the flow of the contrast below the level of the right and left hepatic ducts, which means that there is a tight obstruction at this level. Again, it may be either surgical injury if this patient had just given a history of recent surgery. It may be a malignant stricture again at the confluence. It may be a benign stricture. It may be a ligation by a surgeon if the patient again had a surgery recently. It may be obstruction or compression from outside by enlarged pora hepatis lymph nodes. All these can go as differential diagnosis with this imaging modality. Again, we can see the dilated intrahepatic biliary radicals and dilated right and left hepatic ducts as a result of this obstruction. Okay, so the next imaging modality we are moving on is the T-tube cholangiogram. And a T-tube cholangiogram is summarized into this image. It is done through injection of a contrast into a tube that is inserted inside the common bile duct. So let's go slowly on this aspect. So to do a T-tube cholangiogram, what I need to say is that you can never do it unless the patient had a common bile duct exploration, which is contrary, okay, to the other imaging modalities such as ERCP or PTC or ultrasound, or as we will see MRCP, which can be done on a version, or as we say, a non-operative common bile duct, a normal common bile duct that has never been touched before. Okay. However, a T-tube cholangiogram, it's a cholangiogram that is done through the T-tube. And what's a T-tube? A T-tube, it has this shape. Okay, it's a rubber or latex tube that has the shape of a T. This vertical limb is usually inserted within the common bile duct. So how would I insert it? Definitely I would have to open the common bile duct. So usually these patients who have a T-tube inserted usually have done a common bile duct exploration surgery. As you can see here, this is the vertical limb inside the common bile duct. This is the horizontal limb coming out of the bile duct and then coming out of the skin to be connected to a bag to drain the bile. So this T-tube, what is it indicated for? Why would I resort for putting a T-tube? As a surgeon, this T-tube is usually placed preferentially. And what do you mean preferentially? It means that it's not a routine at all, but however I can assess what's the correct time that I need to put a T-tube. No, I need to not put a T-tube in this case. Usually it is indicated whenever there was excessive manipulation of the inside of the bile duct. Okay, whenever there was a tightly impacted stone in the distal bile duct. There were multiple stones that requested me to use the Desjardins forceps to go in, grab the stone, take it out, and then go in again, grab another stone and take it out, and so on. This multiple trauma to the inside of the bile duct helps to form what we call a wall edema. So this wall edema definitely will lead to what we call a transient bile duct obstruction, because it will encroach upon the lumen. So in an attempt to stent the lumen and prevent this obstruction, we can put the T-tube. Okay, in the old era, surgeons resorted to put a T-tube whenever there was a tight obstruction down there and they couldn't solve it. So they just resorted to put a T-tube. However, this situation is not valid anymore because a T-tube is not a definitive treatment. We can just put it for a few days, few weeks, and we have to take it off because it cannot stay in the patient's common bile duct forever. Okay, so the situation is that we have opened the bile duct, we have inserted the T-tube, and then the patient goes out of the operation room, and then at post-operative day 7 or 10, we usually do a T-tube cholangiogram to make sure of 2 or 3 things. Number 1, we need to make sure that we did not miss any stone inside, because this patient had a common bile duct exploration to extract the stones, as we said before. And since I have been doing excessive or rough manipulation, or if the bile duct was not that much dilated, which I mean despite it's more than 7 or 6 millimeter, however it's less than 12 millimeter, so it means that it's not that much dilated. So sometimes we may resort to put a T-tube to prevent excessive repair of the bile duct that would encroach upon the lumen and lead to stricture or kinking of the common bile duct. So I need to make sure that after finishing my clearance of the common bile duct from stone surgery, I need to make sure that I did not have any missed or residual stone. This is number 1 in the T-tube cholangiogram. Number 2, I need to confirm that the contrast that is injected through the T-tube is flowing freely through the second part of the duodenum, which means that I don't have any distal obstruction. Okay. Number 3, I need to make sure that there is no contrast extravasating from the T-tube exit site, as we can see. This is kind of like a shape of, we would say, a normal T-tube cholangiogram or a T-tube cholangiogram without much pathology. So what we can see is that there is imaging showing contrast within the biliary tree, slightly dilated intrahepatic biliary radicals, and this is normal because this is an operated upon common bile duct which has been dilated. So don't be astonished, it's a dilated bile duct because it had a pathology. Okay, but what we need to see is that we can see that a tube is coming from the middle of the bile duct coming out, and this is the T-tube. So this is the key for diagnosing a T-tube cholangiogram. And we can see that there is slight narrowing here, and this is usually consistent with the repair of the cholecystectomy or the opening of the bile duct around the exit site of the T-tube. And we can look at the whole length of the common bile duct. We don't find any filling defects. which is good. We don't have any missed stones. I look at the contrast, and is it filling the common channel and the duodenum? And yes, it's filling the common channel and the duodenum, which means that there is free flow of the contrast into the duodenum, which means again that I don't have any significant distal obstruction. There is no stricture, there is no missed stone, and there is no exit site leak at this region. So I have a pretty good looking T-tube cholangiogram, and I can tell the patient the T-tube cholangiogram looks good. In 24 hours we'll be completely removing this T-tube, and you will be returning to your normal life within 24 hours. But how if we have a missed stone, how would it look like? So this is again a biliary tree that is taken by image, and I can see that there is a tube coming out from the middle of the biliary tree, okay, and I can see that the contrast is filling the biliary tree except this rounded structure. This is a single distal filling defect, and in this time I wouldn't just call it this is a stone or a missed a filling defect significant for a stone. No, this is a missed or a residual stone. And why do we have to give it this prefix? Again, because putting a T-tube is done only through a patient who had undergone common bile duct exploration. And why did he go through a common bile duct exploration? Definitely he had intracholedocal common bile duct stones. So he did a surgery to clear the stones. So if he came out of the surgery and he is having stones, we call them residual stones. They are missed stones. They should have been removed within the index surgery. However, it didn't happen for a reason or another, whatever. So we call them missed or residual stones. This is the case for T-tube cholangiograms whenever we find a stone in the T-tube cholangiogram. This is another image again showing biliary tree photographed, and I can see there is no endoscope, there is no Shiba needle, there is no pigtail catheter, but I can see a tube coming from the middle of the common bile duct, and this is a filling defect with complete obstruction. Here we can see complete obstruction to the flow of the contrast. There is non-visualization of the duodenum, in contrast to this image where I can see a filling defect, but the contrast succeeded to go to the duodenum. So this means that despite this stone is there, it's missed stone. However, it's not a completely obstructing or a tightly obstructing stone. It's a floating stone around which the contrast has went into the duodenum. So this patient is not having a serious trouble compared to this patient who is having a tightly impacted stone that prevented the contrast from going into the duodenum. So here I have two problems: non-visualization of the duodenum or arrest of the flow of the contrast into the duodenum, which means that I have a tight distal obstruction, and we have a missed stone. This means that I can never remove the T-tube from this patient unless I can get this pathology sorted out. Okay, I have to go with the patient again for the OR and remove this sizable stone. Okay, however, the situation is different here because this is a tiny stone. Again, we said within 1 centimeter we can usually remove it, okay, using ERCP. I hope you got it. Okay, then we will move to the MRCP, or the magnetic resonance cholangiopancreatography, and it is an imaging modality by which the patient roughly takes magnetic waves through his body, and these magnetic waves will meet either fluids or soft tissues or hard tissues like bone. So whenever it meets soft tissues, and we know that MRCP is the imaging of soft tissue, it will give shades of gray. Okay. However, if it met fluids, especially static fluids that do not move or slowly flowing fluids, it gives the whitish color, okay, that appears in the MRCP. That's why static fluids, like for example bile within a gallbladder, urine within a urinary bladder, an abscess cavity, or slowly flowing fluids like bile within the bile duct and the biliary tree, intestinal fluid within the small intestine, gastric juice within the stomach, pancreatic juice within the pancreatic duct, lymphatic vessels, all these are slowly flowing fluids. Again, they appear whitish in color. That's why it's very important to identify that MRCP is the imaging modality or the cholangiogram that never uses a contrast to be injected through the bile duct. Okay. However, it's all a matter of physiology. Okay, so let's look at an image of the MRCP. This is an MRCP and it's showing this is the gallbladder. Again, it's whitish in color, not because of a contrast, it's because it has static bile in it at the time this MRCP was taken. We can see this is the intrahepatic biliary tree, right? This is the left hepatic duct, this is part of the right hepatic duct, common hepatic duct, this is the cystic duct, this is the common bile duct, this is the pancreatic duct, okay, and we can see all of them non-dilated. This is the stomach, this is the gastric juice, again whitish in color because it's slowly flowing compared to the blood, which is rapidly flowing. This again the duodenal juice, like gastric juice and bile and pancreatic juice in the second part of the duodenum. This is a normal MRCP finding. What if we put this image beside this image? So now what we can see is that we can see dilated intrahepatic biliary radicals compared to this. You can see the hepatic duct is hugely dilated, the intrahepatic biliary radical is dilated, the common bile duct is hugely dilated, the pancreatic duct is there. Okay, this is again the duodenum. Since again there is juice inside the duodenum, we will say it whitish in color. And what we can see if there is a defect here. And since we do not fill the bile duct with a contrast, please avoid saying this is a filling defect. No, it's not a filling defect because we don't fill the bile duct with contrast. So we have to call it a signal defect. The magnetic waves are going through the body until they meet a hard object, they never go back. So that's why when they meet a bone, they don't go back. When they meet a hard object like a stone, they don't go back. So this signal has a defect. It never appears on the image that is depicted later on. So this is a single distal signal defect, okay, that is in the common bile duct, which is significant for a single distal common bile duct stone. This is another image showing again dilated intrahepatic biliary radicals, dilated common bile duct, the pancreatic duct is within normal. I can see this is the gastric juice and this is the first part of the duodenum, this is the second part of the duodenum. I don't care much about them, but what I can see here is that there is a single distal signal defect, as we can see here, with the famous what we call the meniscus sign. This is very important. The meniscus sign is a sign that has a convexity, okay, or concavity depending on from which side you are looking at, okay, and it means that there is an impacted stone within the distal end of the bile duct. So this is the meniscus sign. This is again significant for a single distal common bile duct stone. Again, this is an MRCP and it shows dilated intrahepatic biliary radicals, dilated right and left hepatic ducts and the common bile duct. There is a dilated pancreatic duct, but we don't see any signal defects. However, since we said that there is a dilated bile duct, there is a dilated pancreatic duct, we can see an obstructing almost, we can estimate that there is an obstructing lesion here. This is again a double duct sign. Two dilated ducts and an obstructing lesion here. There is a double duct sign which is significant for a pancreatic head mass. Okay, and again we said the pancreatic head mass may be significant for pancreatic head cancer or chronic pancreatitis that leads to fibrosis. This is again another image for an MRCP showing double duct sign, dilated common bile duct and dilated pancreatic duct with intrahepatic biliary radical dilatation. This is the gallbladder. As we say, it can be usually seen by MRCP because it's full of static bile. This image shows, this is an MRCP again, as we can see, this is the biliary tree, this is the duodenum, this is the gastric content, this is the gallbladder, and it shows dilated bile duct, dilated intrahepatic biliary radicals. However, the pancreatic duct is normal, so definitely I have the pathology just within the bile duct. I don't see any signal defects, so it's not a stone, but what I can see is there is a shouldering or tapering towards the distal end of the bile duct, which means that there is a distal common bile duct stricture, and we have said that there are many differential diagnosis. It may be a benign stricture, it may be a malignant stricture like cholangiocarcinoma, it may be a periampullary tumor, it may be a compression from outside by any pathology like a diverticulum. There are many things that may give this shape. Usually it's a benign or a malignant stricture like cholangiocarcinoma. This is again an MRCP showing dilated intrahepatic biliary radicals and showing dilated fusiform dilatation of the bile duct, and it's similar to the fusiform dilatation we have seen in the bile duct by ERCP. It's again type 2 choledochal cyst that has this famous fusiform shape, and this is the duodenum and this is the rest of the bile duct. The last thing we will move to, and we just talk briefly about it, is the computed tomography or the abdominal axial CT scan. And the advantage of the CT scan is that it can give you an idea about the character of the pathology. It can identify benign from malignant lesions. It can do staging of the lesion if it is malignant. It can give you an idea about the staging of the tumor, if it is localized to the organ, if it is locally advanced with surrounding lymph nodes, with direct extension to the surrounding tissues, if it is advanced stage 4 with multiple metastases within the liver, within the peritoneal cavity. So this is the advantage of a CT scan. Whenever we found by any of the aforementioned imaging modalities of the biliary tree, we did initially to identify a pathology, and we need then to move on with this pathology. If it is suspected to be malignant, we have to do a CT abdomen. So abdominal CT is very famous for pancreatic head masses, and when we look at a pancreatic head mass, we just need to identify that this is the abdominal cavity. If the patient is sleeping on the table, imagine that the patient is sleeping on the table, his head is away from your screen and his leg is towards your face, so he is lying on his back. Okay, this is his right hand side, this is his left hand side, this is the liver on his right hand side, this is the spine. In front of the spine lies the aorta. Okay, and next to the aorta on the right side is the IVC, and here the IVC you can see it giving the left renal vein that goes between the aorta and the superior mesenteric artery in what we call a nutcracker mechanism. This is the bowel loops with contrast inside. Here the CT scan, it requires usually a contrast, whether it's an oral contrast taken for bowel or parenteral contrast or IV contrast for viewing the vessels. Here we don't see the vessels having that much contrast. Okay, as we see here, this is the duodenum, second part of the duodenum. This is the pancreatic head lying on the IVC, and we can see those two very important rounded structure. To the right side is the superior mesenteric vein, and next to it on the left side is the superior mesenteric artery, and those two vessels gain their importance from the fact that we can detect resectability of a pancreatic head cancer by the relation of the pancreatic head mass from these vessels. Whenever there is excessive contact more than 180 degrees with the vein, and there is stricture of the vein, or there is any contact of the mass with the artery, usually it renders the tumor irresectable, or what we call a borderline resectability. Okay, and a percentage that you should understand in patients with pancreatic head cancer, that only 10 to 15% of all the patients who present with obstructive jaundice or malignant obstructive jaundice due to cancer of the pancreas, only 10 to 15% are actually resectable, and the rest are irresectable due to many reasons. One of them is that there is a contact between the mass and those vessels, which renders them irresectable, especially the superior mesenteric artery, or it's far more advanced to have central liver metastasis or peritoneal deposits, or making ascites, malignant ascites. If we took an image more proximal to this, we can see the bile duct, because at this level we can see the lesion only, but what did this lesion lead to? And that's what we say the double duct sign that can appear in the ERCP or the MRCP. This is the double duct sign. This is the dilated common bile duct in the head of the pancreas, and this is the dilated pancreatic duct. Okay, and as we can see, this is a higher level. As we can see the gallbladder here. Here we can see that there is a contrast within the aorta. This is the beginning of the celiac trunk. These are the kidneys again, and this is what we need you to know about the CT scan. So let me, by the end of this lecture, I hope that you have gained some information and to learn what I have said by heart, and to clearly identify the different types of cholangiograms or biliary tract imaging. Now we have 4 types of cholangiograms that you need to identify and separate, okay, from one another. the ERCP, the PTC, the T-tube cholangiogram, and the MRCP. If I showed you those 4 images, and if I need to give you an algorithm to easily diagnose each one of them, which is the ERCP, which is the PTC, which is the MRCP, and which is the T-tube cholangiogram. So I will tell you 3 significant key marks to identify each image. Number 1, you have to ask yourself, what is the type of the image taken, okay, or the imaging modality by which this radiology was taken? Which I mean, ask yourself, is the image I'm looking at an X-ray or it's not an X-ray? So how would I know that the image in front of me is an X-ray? So you have to look for the X-ray as an imaging of bones. You have to look for any bony tissue. If I can see a bony tissue like the spine, so this is an X-ray. If I can see shadows of the ribs, this is an X-ray. Okay, we have 3 imaging modalities or 3 cholangiograms under the big name of X-ray. You have the ERCP, you have the PTC, and you have the T-tube cholangiogram. And each one of these, as we said, we need to inject a contrast. The 4th cholangiogram, which is the MRCP, it's done by MRI, which is an imaging of soft tissues. So you are not supposed to see any bony tissue. You are not supposed to see spine next to the bile duct. You are not supposed to see ribs. So this is the first question you should ask yourself. Is the image I'm looking at, is the biliary image I'm looking at, is taken by X-ray or not? If you see any bony tissue like the spine as we see here, so this is an X-ray. So now I have 1 out of 3 options. If it is an X-ray, either it's an ERCP or a PTC or a T-tube cholangiogram. The easiest if it is not an X-ray, because this will give you just one single option to be taken, which is the MRCP. Okay, so this is the easy. If it's not an X-ray and there is a biliary tree, so done, you are an MRCP. But if it is an X-ray, I can see a bony tissue here, so this is an X-ray. Okay, so an X-ray, maybe it's an ERCP, maybe it's a PTC, maybe it's a T-tube. So I have to move myself to the second question. As long as this is an X-ray, so I have to inject a contrast. I have to inject a contrast to view this lumen, which is the bile duct. My question is, how did the contrast reach the bile duct? When you answer this question, you will be able to identify the image. So if the contrast is injected via an endoscope like this, and I should see the key, so which will give me like a chit chat, so this endoscope is significant for ERCP. So the contrast has been injected via catheter inserted through the endoscope. If I don't see an endoscope and it's still an X-ray, so it's not an ERCP, but maybe it's a T-tube cholangiogram or a PTC. So let me look for another way. Maybe this contrast has gained access into the biliary tree. So if the contrast injected through a needle or a catheter that goes through the uppermost or the highermost aspect of the biliary tree, you see here the endoscope was coming to the most distal aspect of the biliary tree. On the contrary, this is the PTC. There is a catheter or a needle going through the highermost aspect of the biliary tree. So this is a PTC. If you find an X-ray, you find a biliary tree, but you don't find an endoscope, it's not an ERCP. You don't find a catheter or a needle going through the intrahepatic biliary radicals or the highermost aspect of the biliary tree, so it's not a PTC. Then look for the third option, where you should find a catheter coming from the middle of the bile duct. So if I would say that I need to highlight those key factors for images taken by X-ray, I will make them yellow like this. So these 3 images are X-rays. These images have biliary tree with contrast inside. I need to know how the contrast was injected. One is by this yellowish endoscope, so it's an ERCP. One is by this yellowish catheter, or it may be a needle, just a sharp needle, so it's a PTC, or one may be with a catheter coming out from the middle of the bile duct, so it's a T-tube cholangiogram. This is how you identify PTC from ERCP from T-tube cholangiogram. However, the MRCP is the easiest because it doesn't have any bony tissue around. Okay, so finally by this I came to an end of the lecture. I hope it was as much informative as possible, and I wish you the best of luck in your study, and definitely I'm open for any questions whenever you have, and good luck. Thank you.